Hi, my name is Chitty and I'm a Research Fellow from the University of Sydney in the newly formed discipline of Biomedical Informatics and Digital Health. I also have a visiting appointment at the University of Western Australia at the School of Population and Global Health. And today I'm going to be talking about our study, the ASHLI study, and this is the Australian Suicide Prevention Using HealthLink Data Study. This has been funded by an NHMRC project grant. And today I'm going to be talking about the protocol for this study. It's taken us about 5 years to get us to this point where we've finally got all the data and everything's together, it's all approved, and we're about to start analysis in the upcoming year. It's very exciting. The protocol for this study is actually been published in BMJ Open, so if you do want any other information, you can refer to this paper, but also feel free to send me an email if you're interested in the study or any collaborations. We're very open to that. Okay, so in Australia, suicide is the leading cause of years of potential life loss, the leading cause of death for 15 to 44-year-olds, and the rates have remained largely unchanged over the past decade. So it's a real public health priority in Australia and indeed all over the world. So when we're talking about effective suicide prevention strategies that are delivered by health services, the most effective are GP training and gatekeeper training, and also delivery of psychosocial treatments. And so when we say training here, we're referring to training GPs and other people that come across, other health professionals that come across people at risk of suicide, in being able to identify people at risk of suicide and then give them the appropriate treatments or refer them appropriately. Outside of the scope of health service suicide prevention, means restriction is also a highly effective strategy in preventing suicide. So what we don't know is the proportion of people who will visit a GP, have contact with gatekeepers, or receive psychosocial treatments before they die of suicide. So although we know these are can be effective suicide prevention strategies, we don't know exactly what the reach of these suicide prevention strategies are. We also don't know what medicines that have been, we don't know the medicines that have been prescribed to people that die of suicide in an epidemiological sense. We also don't know what proportion of people that die use their medicines for self-poisoning. So this represents kind of an area of means restriction that that needs further information. So therefore, the aims of the ASHLI project are to describe and characterise health service utilisation rates, and this is both general and mental health, in the year prior to death by suicide, and how this varies by individual case characteristics. And we also want to look at the prescribed medicine use in the year prior to death by suicide, the medicines that are used in suicide by poisoning, and how this varies by individual case characteristics. So this is a population-based case series study, and the cases we're using are all suicides identified through the National Coronial Information System, or the NCIS, that occurred in Australian residents between July 2013 and October 2019. And I need to highlight here that suicides identified through the NCIS do not represent all suicides in Australia during this time frame. These are the ones where the case has been coded as complete by the coroner, and of course there's a lag to that. So those in 2018 and 2019 may not be completely closed, and therefore we have an under-ascertainment toward the end of this time frame. And the reason why we're only taking those where cases have been closed is because we need the maximum amount of information that we can possibly have from the coronial records, and we want it to be the most up-to-date and accurate. So all these cases that then have been now linked to health service and medicine use in the year prior to their death. The linkage is conducted by the AHW, IHW and Cheryl for the New South Wales specific data. So now I'll just go through the specific data that we have linked now. So firstly, we've got the coronial cases information, and that's coming predominantly from the NCIS, but also where we've got the NDIA records, which is the National Death Index records. So we'll have the coronial determination of cause of death, but also we just want to look at what's actually recorded in the NDI to see how well this matches up. Also from the NCIS, we're taking information from the police reports, from the autopsy reports, but predominantly from the toxicology reports. We want to know what medicines or what was found in the toxicology report in terms of what was present at time of death, the amounts, and whether any of these were, and the concentrations that were found at time of death. We're looking at medicine dispensing claims, and we're getting this from the PBS, the Pharmaceutical Benefit Scheme, and we're looking at health service records. We're getting this from the MBS, so Medicare Benefit Scheme, and that's for Australia-wide, so those close to 15,000 cases. But then in New South Wales only, we're also looking at hospital records. And ideally, we would like hospital records for all the cases in all of Australia, but that's a little bit beyond the scope of the approval process for this study at this stage. It is an aim going forward. And so from New South Wales, we're using the mental health ambulatory data set, the emergency department data collection, and the admitted patient data collection. So our planned analysis for AIM 1, which is focusing on the healthcare utilisation before suicide, we really have two prongs. So the first prong is, who is making healthcare contact before suicide? Are there any patterns in terms of age and sex and other demographics that we can use to kind of characterise these people who are making healthcare contact? And then when they're making healthcare contact in terms of proximity toward death, and what healthcare contacts are they making? And how does this, are there patterns in terms of this in terms of age and sex? So you have older females more likely to see a GP, whereas younger females might be more likely to see their psychologist, for example. These are the questions that we really want to tease apart here. And then the second prong is, who is not making any healthcare contact before suicide? Are there any patterns in terms of age and sex? And what parts of Australia do they live? And when we talk about what parts of Australia do they live, we're really talking about statistical area 3. So we're looking at really large areas, but we want to see, okay, so how does remoteness impact what healthcare contacts you're likely to be making? And of course, we know from previous research that people in very remote areas of Australia are, of course, less likely to make healthcare contact. But in these areas, who are seeking help, and what contacts are they seeking, if any? If not, what suicide prevention initiatives can we focus toward these areas? That analysis for AIM 2 is similar. There is two prongs. So of course, this is medicine utilisation before suicide. So who is taking prescribed medicines at time of death? Are there any patterns in terms of age and sex and other demographics? What medicines are they taking? So this is going to be a really large part of the project, is just basically characterising all the medicines that have been taken, what combination and in what combinations. And are these medicines involved in the suicide? Are they involved in the poisoning? And of course, we know this because we have the toxicology reports, we have the autopsy information. So the second prong, who is not taking prescribed medicine at time of death? Are there patterns in terms of age and sex? What parts of Australia do they live? And are they instead making healthcare contacts? And so, of course, this is going to give us a lot of information about hopefully means restriction and where in Australia this needs to be targeted. So finally, what do we hope this information will do for suicide prevention? We want to identify the reach of suicide prevention initiatives that are delivered by health services. How many people are actually making contact with these health services? We want to highlight the barriers to health service utilisation. We want to provide information to help target means restriction in terms of medicines. And we may be able to highlight potentially harmful medicine use, so medicines that are prescribed in combinations that are overrepresented in our sample of people